Welcome back to the Deep Dive, where we extract the core intelligence from global research and, well, we put it directly into your hands. Today, we're wrestling with two really colossal forces that are shaping the future of human well-being. First, the critical and frankly looming crisis in healthcare staffing around the world. And second, the revolutionary, and I think it's fair to say, very complicated role that artificial intelligence is set to play in trying to fix it.
It is. And this is a deep dive that's really driven by some essential source material. We have on one hand a fundamental reevaluation of the global health workforce. This was conducted by the WHO and published in the BMJ Global Health. And that gives us the raw, updated numbers on, stock and shortage projections. Then, paired with that, we have this really ambitious analysis from Lancet Digital Health. And that one explores the transformative power of generative AI in training the next generation of medical professionals.
So our mission today is to cut through all the noise. We need to figure out if the positive global progress in health worker numbers is truly equitable. Or, are we just masking these deep localized crises of capacity? And crucially, we have to weigh whether this technological promise of AI can realistically bridge those severe structural gaps that the global data has identified.
It's the ultimate tension, isn't it? You have the data showing us exactly where we are failing, and then you have technology offering us what looks like a potential shortcut. Understanding that friction, that tension between the data-driven reality and the technological promise is just absolutely essential if we want to talk seriously about achieving universal health coverage.
I agree. Let's start by grounding ourselves in the history here. The global community has known about this crisis for nearly a decade. Back in 2016, a major alarm was sounded based on the Global Strategy on Human Resources for Health, the GSHRH. What was that defining and, I have to say, terrifying figure we were all dealing with back then?
The original alarm, it all focused on that workforce 2030 projection. And the number, the one that really captured the world's attention, was an estimated global shortage of 18 million health workers by the year 2030.
18 million.
18 million. That figure became the benchmark for a decade. It basically signaled a guaranteed catastrophe if global trends continued unchecked.
18 million is just a number so vast it's hard to even contextualize. But the researchers now are noting that since that original projection, the way we actually measure the workforce has improved dramatically, in fact. What changed?
The main improvement really is the systematic implementation of the WHO's National Health Workforce Accounts. You'll see it called NHWA. Before this system, a lot of countries had fragmented data or just incomplete data, especially for occupations outside of, core medicine and nursing. The NHWA framework now gives us a standardized global place for all this country-reported data. It acts as the central monitoring mechanism.
So better standardized data collection gives us a much more stable baseline to work from. We're moving past the uncertainties of that 2016 model.
Precisely. We now have much, much clearer figures, particularly in those previously undercounted groups. We're talking pharmacists, dentists, other allied health professionals. Their collective contribution is absolutely vital to primary care, but they were sort of in the shadows of the data before. This improved reporting is what allowed the researchers to even undertake this kind of comprehensive reassessment.
Okay, let's move directly into that present reality then, using this improved NHWA data. Based on the latest figures, what was the total global stock of health workers in 2020?
The updated stock figure for 2020 is 65.1 million health workers globally. That's across all categories. Now, that number on its face is encouraging. It signals a massive, complex, and vital global employment sector.
And the WHO analysis focuses very heavily on 5 main occupational groups, the ones relevant to the Sustainable Development Goal health worker target. Can you break down that subset for us?
It's about 50 million, right? That's right, 50.1 million in that core group. And this is where that improved counting really shines. The largest group, by a significant margin, is nursing personnel. That's 29.1 million people globally.
Wow.
Yeah. That one category represents nearly a third of the entire global health workforce stock.
Just nurses.
Just nurses. And then following them, you have 12.7 million medical doctors, 3.7 million pharmacists, 2.5 million dentists, and 2.2 million midwives.
That distribution really highlights just how reliant our global health systems are on the nursing profession. But the real good news, globally speaking, is the rate of growth you mentioned.
It is. It's the single most positive trend they identified in the data. The net growth between 2013 and 2020 resulted in an additional 14 million jobs. That translates to a 27% increase in the global health workforce stock. And to put that into perspective for you, the global population only grew by 8.2% in that same period.
So we were hiring health workers at a rate over 3 times faster than the rate of global population increase. That pace has fundamentally changed the trajectory.
It absolutely does. I mean, when a system is growing that much faster than the demand driver, the catastrophic projection has to be revised downward. And that is exactly what happened when they calculated the updated shortage.
Okay, let's get right to those revised numbers. If we're growing this fast, that initial 18 million shortage for 2030 must have come down a lot. What's the new projected shortage for 2030?
So the initial 2020 shortage was revised down to 15.4 million. But based on the current trajectory, and this assumes consistent graduate output and employment rates, the shortage is projected to drop to 10.2 million by 2030.
10.2.
10.2 million. That's a massive achievement.
Yeah.
It means the global shortage is projected to decrease by 34% since 2020 and nearly 50% since that first assessment back in 2013.
That is fantastic news on a global level. It really transforms the conversation from one of, like you said, guaranteed system collapse to one of manageable, if still challenging, targeted interventions.
It shifts the narrative completely. And again, the sources emphasize that part of this reduction is methodological. The better data collection on those previously neglected health occupations shows their existing capacity. They were already contributing toward universal health coverage, it just wasn't fully reflected in the 2016 calculation.
Okay, but before we celebrate too much, we need to clarify how they're defining a shortage. What's the technical benchmark they use to decide if a country is contributing to that 10.2 million figure?
The benchmark is a density threshold. Specifically, it's the ratio of health workers to the general population. The researchers set this threshold by looking at the median density of those 5 key occupations: doctors, nurses, midwives, dentists, and pharmacists, as they stood globally back in 2013. That calculation resulted in a combined density threshold of 51.2 health workers per 10,000 population.
51.2.
Right. So any country that falls below that 51.2 threshold is considered to have a shortage, and they contribute to the overall global figure.
So if a country has 50 workers for every 10,000 people, it's in the red. But here is the critical pivot, isn't it? A shrinking global crisis often hides a deepening crisis of distribution and inequity. What does the data show about where these health workers actually live and work?
This is where the celebration stops and the real concern begins. The distribution reveals a shocking level of inequity. In 2020, high-income countries had a health worker density that was 6.5 times the density found in low-income countries.
6.5 times.
6.5 times the concentration of trained professionals. That level of capacity disparity, I mean, it fundamentally undermines the very idea of global health equity.
It has to.
It does. And look at the numbers in relation to population. High-income countries, which account for only 22% of the world's population, just over a fifth, they have close to half, 47% of the global health workforce. And while the sources note a marginal decrease in this inequity since 2013, when it was even worse, the absolute distribution remains grossly, tragically skewed.
So the global stock is growing, but it's growing where the stock is already concentrated. Which regions specifically are showing no signs of catching up?
The analysis really highlights the WHO African and Eastern Mediterranean regions as the epicenters of this stagnation. These regions showed almost no material improvement in their shortages between 2013 and 2020, and their 2030 projections look grim. The African region's shortage is only projected to decrease by 7%, and the Eastern Mediterranean region by 15%. Those figures are almost statistical noise compared to the global 34% decrease.
Why are they struggling so severely? Is it just a matter of not being able to train enough people?
It's a really complex structural issue. Firstly, the sheer population growth factor is just overwhelming any training gains they make. Between 2020 and 2030, the African region is projected to grow by an astounding 28%. The Eastern Mediterranean by 18%.
Wow.
And you compare that to the population increase in most other WHO regions, which is around 5%. They are literally running on a treadmill that is speeding up underneath them.
That explains the rising demand, for sure. But we also have to think about the retention side of things. Why can't they sustain a workforce even if they manage to train them?
This is a critical point that goes way beyond simple population dynamics. These countries often face systemic challenges, things like brain drain and restricted fiscal capacity. Health workers in these regions are highly susceptible to international recruitment, which is often targeted and frankly, aggressive by high-income countries. So when a country invests heavily in training a doctor and that doctor leaves for much higher pay and better conditions somewhere else, that entire investment is lost. And on top of that, their reliance on external aid or unstable national revenues often restricts the public sector's ability to sustainably create and pay for new, permanent jobs. If a country can't afford to absorb, say, 70% of its new graduates, the whole system just stalls out.
So if the crisis is shrinking globally, but it's staying stagnant in those two rapidly growing regions, the shortage is becoming profoundly concentrated in just a handful of countries. Let's focus on those 47 countries identified as being the most vulnerable.
We're talking about the WHO Health Workforce Support and Safeguards List, or the HWF-SSL. This list is made up of 47 countries that already accounted for half of the total global shortage back in 2020. They're monitored because they're highly vulnerable to health worker migration and their health systems are just severely, severely stressed.
And what is the data project for these 47 countries by 2030?
The concentration is the single most alarming finding in the entire study. By 2030, these 47 HWF-SSL countries are projected to encompass a staggering 69% of the remaining global health workforce shortage.
69%.
Let's just pause on that figure. If the total global shortage is 10.2 million, roughly 7 million of those missing workers will be concentrated in just these 47 nations. This is not a global health crisis anymore. It's a profound, localized equity failure that threatens the entire framework of universal health coverage.
You also mentioned that small island developing states, SIDs, face a different but equally challenging set of circumstances that are holding them back.
Absolutely. The SIDES countries showed much, much slower progress. Their health worker density only increased marginally between 2013 and 2020. Their unique challenges are structural. They struggle with economies of scale. It's just difficult and very expensive to establish and maintain large, high-quality national medical schools for a small, dispersed population.
And SIDs are uniquely vulnerable to climate and geographical issues, which must complicate service delivery to an extreme degree.
Exactly. Service delivery is a nightmare because of the geography itself. Many citizens live in these hard-to-reach island communities. And beyond that, SIDs are highly exposed to catastrophic climate events like severe hurricanes or sea level rise. Those place immediate, overwhelming pressure on their already limited health infrastructure and workforce. They just don't have the resilience or the training capacity to scale up rapidly.
Okay, before we look at technology as a potential solution, let's critically examine the foundation of this optimistic 10.2 million projection. What are the modeling assumptions that underpin this figure?
The projection relied on a standard stock and flow model, looking forward 10 years from that 2020 baseline. It accounts for attrition, so workers leaving the profession primarily through retirement, which they model at age 65, and replenishment, which is the flow of new graduates entering the workforce.
But the most crucial assumption, the one that really makes or breaks that 10.2 million figure, it has to relate to whether those new graduates actually get jobs.
Right. It's the single most sensitive variable in the whole model, the health system's absorption capacity. The model operates on the assumption of a fixed 70% absorption capacity.
70%.
Right. That means the researchers assume that 70% of new graduates are hired and successfully integrated as practicing health workers. This figure was estimated based on historical OECD data across various occupations, so essentially projecting Western trends onto a global scale.
Okay, let's challenge that 70% assumption for a minute. If we know that the shortage is concentrated in regions with restricted fiscal space because of economic instability or aid dependency, why are we accepting this high figure? Why focus so much on the 10.2 million projection?
That is the responsible question to ask, and the researchers themselves acknowledge that this 70% figure is fragile, particularly in light of the global economic uncertainties that followed the COVID-19 pandemic. A post-pandemic recession or even a slow recovery limits government revenue and, as a result, limits public spending on health. If governments can't afford to expand their payrolls, they can't create those critical entry-level jobs.
So if that economic assumption is shaky, what does the worst-case scenario look like?
They ran a sensitivity analysis to address this very fragility. If, for instance, we assume a lower absorption capacity, particularly in lower-income countries, say reflecting real-world economic constraints, the projected stock of health workers by 2030 drops from 84 million down to 76 million.
And what does that do to the shortage number?
The shortage number jumps significantly, up to 12.9 million. That 12.9 million figure is likely a more responsible, risk-adjusted number to plan around than the optimistic 10.2 million. The core takeaway here is that sustained, high-level public investment, ensuring that high absorption capacity, is absolutely necessary to realize the progress in that smaller shortage number. If the money isn't there to hire them, training them isn't going to solve the problem.
And we have to remember that these projections largely depict a pre-COVID-19 situation. The pandemic's long-term scars, they haven't fully factored in yet.
That's the final crucial caution. Beyond the economic constraints on hiring, the pandemic caused immeasurable stress. We've seen increased rates of burnout, mental health challenges, and potential increased attrition among existing staff who might retire early or leave the profession entirely. So that 84 million projected stock for 2030 and the corresponding optimistic shortage figure, you have to view it as a best-case scenario that's dependent on global economic and public health stability that, frankly, may not materialize.
Okay, so we've established a deep, painful structural problem. A global shortage that is rapidly clustering into a localized crisis in these 47 high-risk countries. And that's compounded by the economic uncertainty of whether we can even afford to hire the graduates we produce. This intense pressure leads us directly to the search for solutions, and that means turning to technology.
Exactly. Given that the traditional medical school capacity in so many LMICs is inadequate, it just can't scale fast enough to meet demand technology. Like, artificial intelligence is seen as the essential lever. The goal is clear. Use technology to create scalable, low-cost solutions that can broaden global access to high-quality medical training.
And the key technology driving this transformative vision is generative AI, or GenAI. What exactly makes GenAI and its subcomponents, like large language models, so different from the digital tools we were already using, like, say, basic VR simulation?
GenAI is fundamentally different because it actually creates new content, text, images, even video by learning patterns from massive data sets. It's not just presenting pre-programmed information. And large language models, or LLMs, things like ChatGPT, Llama, and DeepSeek, they're designed to process natural language, which makes them conversational and incredibly versatile as tutors.
And the sources highlight that these LLMs are becoming more accessible, which is the crucial point for these resource-limited settings.
That's absolutely vital for the equity discussion. Newer models, ones developed since 2024, like OpenAI's O3 Mini or DeepSeek R1, they're specifically designed to enhance reasoning while operating with reduced computational demand.
Okay, so why does that matter for a rural training center in the African region?
It matters because it means less reliance on expensive, high-performance computing hardware or a constant high-speed connection to some remote cloud API. Lower computational demand means lower hardware costs and better potential for local, decentralized deployment. It makes the technology viable where infrastructure is weak.
So GenAI didn't start the trend of digital innovation in education, but it's acting as a kind of turbocharger. Let's look at how LLMs are transforming fundamental medical education tasks right now.
The transformation is happening across the board. The first area is content generation. I mean, just imagine the time it takes for human faculty to write high-quality, diverse case-based learning materials that are aligned perfectly with a specific medical curriculum. LLMs can generate these scenarios rapidly, allowing educators to focus on quality review instead of just raw content creation. It accelerates the whole process.
And how is it changing the notoriously difficult process of assessment and feedback?
That's the second critical area: assessment and feedback. We've seen natural language processing analyze the nuances in narrative feedback written by human evaluators. So LLMs can support competency-based evaluations by identifying language patterns that are linked to specific milestone ratings. For instance, analyzing a resident's narrative self-assessment for markers of critical thinking or self-reflection, and providing feedback that's both efficient and far more targeted than manual review allows.
And thirdly, how are they helping seasoned professionals or those needing continuous development?
That falls under professional development and clinical support. LLMs are proving excellent in improving examination performance for medical students by providing highly focused drill practice. But maybe more importantly, they offer real-time decision support for experienced physicians. They help them quickly interpret and apply complex, often updated, medical guidelines or policy documents, which augments their clinical judgment on the fly.
That focus on personalization seems like the biggest shift. Instead of a one-size-fits-all lecture, the student gets a tutor that adapts to their specific knowledge gaps.
Absolutely. LLMs enable context-aware chatbots that can specialize in niche areas like neuroanatomy. Or they can power interactive virtual patients designed to test clinical reasoning in a structured, adaptive way. And crucially, these tools are infinitely scalable and low cost once they're deployed. For LMICs, which have severe bottlenecks in medical school capacity, this offers a viable pathway to training a much larger cohort of future health workers without waiting decades for new infrastructure investment.
Okay, let's look beyond text-based learning and into the high-fidelity training environment. How does AI enhance the actual clinical simulation environment, making it more realistic and impactful for a student?
The integration of AI enhances the immersive quality tremendously. Just the conversational aspect of LLMs allows for a less intimidating learning environment than, say, asking a question in a massive lecture hall. LLMs can dynamically adjust their explanations, breaking down intricate subjects like complex physiological processes into simpler, more digestible terms. They're complementing the human educator, not replacing them.
And the concept of the virtual patient has been around for a while, but it sounds like GenAI has fundamentally transformed this capability.
Oh, completely. Traditional virtual patients were often just decision trees. If you press A, the system responds with B. AI-generated virtual patients, however, can simulate diverse, complex clinical scenarios with a depth and consistency that traditional methods just can't match. They can simulate a patient with a rare disease presenting subtly, allowing students to practice history-taking, diagnosis, communication, decision-making, all in a completely risk-free setting and getting immediate personalized feedback.
But the current chatbot-based virtual patients still suffer from a big limitation. They lack physical and emotional cues. You're essentially just talking to text. How are the next generation of GenAI models, especially multimodal models, addressing this?
This is the cutting edge, and it's where the training potential truly explodes. Those limitations, the lack of visual, audio, and nonverbal cues, are being overcome by multimodal GenAI. Advancements in video generation models, notably systems like Sora, mean we can create realistic, high-fidelity videos for training purposes.
So that means we can move past just reading a description of a patient's symptoms and actually see visual representation of them.
Exactly. Researchers are proposing that models like Sora can be fine-tuned using specific medical domain datasets to generate endless clinical scenarios. So instead of reading about a patient in respiratory distress, a student could watch a high-fidelity video of a simulated patient exhibiting those specific signs, allowing them to practice observation skills. You could also combine this with visual language models like GPT-4V, which can interpret image inputs, say an image of an X-ray or a skin lesion, and integrate that right into the conversational training scenario.
So we're talking about an end-to-end simulation. The LLM provides the conversation, the VLM interprets the medical images, and the video generation model provides the realistic physical environment and patient reaction.
Precisely. You could have a video generated of a specific medical procedure, like a colonoscopy, based on multimodal inputs like an image of a polyp. This moves us so much closer to a truly realistic simulation that addresses complex, hands-on procedures, not just cognitive skills. And all this high-fidelity multimodal training finds its integration point in the metaverse.
How does the metaverse tie into scaling training capacity for LMICs?
The metaverse concept merges augmented reality, virtual reality, and AI into these persistent, immersive virtual environments. This facilitates collaborative learning activities that just break down geographical and physical barriers. Think about a resident in rural Kenya joining a virtual grand rounds discussion led by a specialist in London, or a team of students practicing emergency trauma simulation together in a shared virtual operating room.
The reduction of geographical barriers is the key for those highly concentrated shortage regions.
It's crucial. The metaverse facilitates activities like flipped classrooms and team-based learning without requiring expensive physical travel or the construction of costly, centralized simulation centers. It's an essential infrastructure bypass for training thousands of people simultaneously across vast distances.
Beyond clinical practice, let's look at the research side of things. Medical research training is demanding. It's often incredibly time-consuming. How is AI freeing up valuable trainee time?
AI is streamlining the most laborious, heavy-lifting parts of the research process. It dramatically assists with the initial literature review, which can take weeks for a human trainee, and it helps in identifying knowledge gaps. It improves both the efficiency and the sheer breadth of the initial stages of any systematic review, while potentially mitigating human bias or just simple oversight in data collection.
But do we have specific evidence of AI performing these complex research tasks effectively?
We do. The sources cite studies showing the strong performance of LLMs in abstract screening for systematic reviews. This typically requires two human reviewers to manually sift through thousands of abstracts to determine relevance. The data suggests that LLMs can act as a cost-effective, efficient third eye, or maybe even a substitute for one human screener, dramatically accelerating the timeline for these reviews.
Which means students can dedicate their limited time to the higher order tasks, which is what we want them to do.
Exactly. If AI is handling the heavy lifting of compilation and initial screening, students and residents can focus on critical thinking, deep analysis, interpretation of results, the intellectual core of medical research. And beyond that, AI itself is providing new areas of inquiry. Trainees are already exploring how to use specialized chatbots for large-scale patient education, or how LLMs perform when asked to interpret complex medical guidelines. This type of research directly prepares them for an AI-integrated healthcare future.
Okay, you made a compelling case. AI offers scalable, personalized, high-fidelity training that seems perfectly tailored to address the capacity crisis in those 47 HWS SSL countries. But now we have to confront the challenges. If AI is the bridge to universal health coverage, the sources warn us it's currently a bridge riddled with structural, financial, and ethical flaws. Let's start with the central issue: credibility, accuracy, and bias.
This is the most significant hurdle to ensuring AI is deployed safely and equitably, especially in medical education where accuracy is, it's completely non-negotiable. Despite all their sophistication, the reliability of LLMs is constantly under fire.
And the most commonly cited issue is the hallucination problem. Right.
Hallucinations are a persistent core limitation. LLMs routinely generate information that sounds perfectly plausible, is well-structured, but is factually incorrect, fabricated, or based on non-existent sources. In medicine, where students are learning foundational knowledge, if they're exposed to a hallucinated anatomical structure or a fabricated treatment protocol, the consequences are immediate and severe for patient safety. Even when the models try to provide citations, the reliability of those citations remains deeply challenging.
And beyond just factual inaccuracy, there's the problem of systemic bias, which can undermine the entire goal of equity.
This is the quiet, insidious threat. LLMs are trained on vast data sets drawn from the internet and published literature, and that data inevitably contains embedded human and historical biases related to sex, race, and political affiliation. If these subtle biases, for instance, historical underrepresentation of certain ethnic groups and medical images, are ingested by the AI, the model risks perpetuating and amplifying those systemic disparities in its teaching.
And this risk extends even to the visual content generated by multimodal AI, like the Sora models we were just talking about for virtual patients.
Oh, absolutely. If a GenAI image model is trained predominantly on images of certain demographics, the images and videos it generates for education may just reinforce unequal representation. It fails to prepare trainees for the true diversity of patients they're going to encounter. This demands constant, proactive auditing of the training data and the model outputs.
There's also the subtle influence of AI, even when the student isn't directly asking it a question, this concept of model-induced belief revision. Can you elaborate on why that matters?
Model-induced belief revision. It refers to the risk that prolonged exposure to an AI-driven learning environment subtly shifts the learner's cognitive framework. If an AI tutor consistently provides rapid, perfectly structured, or even slightly biased answers, the learner might stop developing the critical analysis skills needed to wrestle with ambiguity or conflicting literature or just real-world uncertainty.
They start assuming the answer provided by the AI is the definitive, unchallengeable truth.
Exactly. They might lose the cognitive muscle needed to critically evaluate conflicting symptoms or question a textbook diagnosis. In a complex field like medicine, where human judgment is paramount, this dulling of critical analysis is a really serious risk that educators have to actively counter.
Okay, let's shift to the operational and privacy hurdles. In the highly sensitive world of patient data, how vulnerable are these AI models to exposure?
The vulnerability is significant. First, AI models are susceptible to adversarial attacks, where malicious queries can be used to elicit or expose sensitive patient information the model has ingested. Second, even when models are trained on de-identified datasets, they can inadvertently reproduce sensitive data points because of what are called memorization artifacts.
Can you give us a simple analogy for a memorization artifact? What does that mean?
Sure. Imagine you train an LLM on a gigantic book that includes a list of 100 patient names and their rare diseases. The LLM shouldn't remember that specific list, but if you prompt it cleverly, it might spit out one of those specific names and the corresponding disease because it memorized the exact pattern of the training data. This inadvertent reproduction of sensitive, identifiable data, even when training was intended to be secure, poses massive governance challenges.
And these governance challenges are compounded by the commercial nature of many of these LLMs.
Indeed, many proprietary large platform providers operate under terms and conditions that may allow them to share user data, even institutional training data, with third parties, sometimes without explicit and clear notice. For institutional oversight bodies in medicine, this is a huge red flag for patient confidentiality and regulatory compliance.
Now let's address accessibility, which links directly back to the equity crisis in those 47 high-risk countries. The technology is scalable, but is it actually accessible?
The profound irony here is that the regions most in need of this scalability, LMICs, especially in Africa and the Eastern Mediterranean, they face the highest barriers to effective use. The single biggest access hurdle is the language requirement.
Explain the language barrier beyond just simple translation.
The effective use of LLMs, especially for complex reasoning and academic content, requires high proficiency in English, as most cutting-edge models are primarily trained on English language data. This immediately disadvantages students and trainees who are non-native English speakers. And while some models like DeepSeek natively support languages like Chinese, the investment gap for creating high-quality, reliable LLMs in major local African or Middle Eastern languages remains enormous. Without significant sustained investment in local language model development, the content and benefits remain locked behind an English proficiency barrier.
And this is compounded by infrastructure gaps.
Massively. Effective LLM use requires a stable, high-speed internet connection, compatible, up-to-date devices, and often paid subscriptions to access the best, most reliable models. These are precisely the technological requirements that are scarce in low-resource settings. If you don't have consistent power or reliable fiber optic infrastructure, the promise of scalable training just evaporates. This digital divide is actively widening the inequity gap between high-income and low-income medical institutions.
Which brings us squarely to the financial investment gap. For countries already struggling to meet that 70% absorption capacity target, meaning they can barely afford to hire workers, what are the hidden multifaceted costs of integrating LLMs into their training systems?
The source material really stresses that the costs go far beyond a basic subscription fee. Systematic cost assessments are scarce, but we know the expenditure includes, first, the initial subscription fee, second, the escalating costs due to high query volumes as usage scales up, and third, and most expensive by far, the cost of customization and fine-tuning.
Okay, why is customization so resource-intensive, and why is it mandatory for medical education?
Customization is mandatory because a general LLM, like off-the-shelf ChatGPT, is simply not accurate or safe enough for medical training. It just isn't. To make it reliable, to minimize hallucination and ethical risk, you have to fine-tune it using curated, high-quality medical data specific to your regional context. And this process requires three highly specialized and expensive resources: high-performance computing, access to vast amounts of vetted, curated training data, and intensive interdisciplinary collaboration between AI researchers, clinicians, and medical educators.
And those three resources, HPC, curated data, and specialized staff, are often non-existent in the 47 countries facing 69% of the shortage.
That's correct. The technical capacity simply isn't there, which creates a catch-22. They need the scalable training, but they can't afford the resources necessary to make the tools safe and contextually relevant for their students.
Even the open source models like Llama, which seem affordable, don't solve this customization problem entirely.
They're a good start because they reduce the proprietary licensing fees, but they introduce what you could call the open source paradox. They're free, but the cost of reliably deploying, maintaining, and customizing them is still resource-intensive. For example, researchers at Stanford fine-tuned Llama to create Alpaca, a powerful open-source model. They eventually had to take it offline because the continuous cost of deployment, maintenance, and content moderation filters was just too high to sustain, even after the initial, inexpensive fine-tuning. Affordability is not the same as zero cost.
And this financial hurdle connects directly back to our initial discussion on the economic viability of the entire 2030 projection.
It does. If governments are constrained by post-pandemic economic stress, they can't afford the high public expenditure required for two things simultaneously: maintaining a high 70% absorption capacity to hire new workers, and making the necessary high-level investments in AI infrastructure, data, and customization. The lack of public funds creates a dual crisis: a capacity crisis that training alone can't fix, and a technological barrier that requires funding they just don't have.
Finally, let's just re-emphasize the role of the human educator in this future. The sources are crystal clear. AI is not replacing them.
Absolutely not. AI is a co-tutor. The human educator is indispensable. They provide the necessary clinical context, they model empathy, they guide appropriate use of the tools, and most critically, they must act as the ultimate validator of AI-generated information. Educators have to be prepared to intervene immediately to correct inaccuracies or to address integrity risks, maybe using emerging tools like digital watermarking to identify LLM-generated student work.
This necessitates a huge shift in how educators are trained and supported then.
It requires a massive investment in faculty development. You can have ethical frameworks for AI in education and robust oversight to manage the risks, but faculty need intense training on how to integrate AI effectively, how to identify when it's hallucinating, and how to redesign curricula to leverage the AI while preserving critical thinking skills. This training is itself a significant resource hurdle that has to be overcome, particularly in LMICs, to ensure AI is a tool for equity and not a driver of further disparity.
This has been a fascinating journey through data and, well, future technology.
Yeah.
Let's try to synthesize the core findings of this deep dive.
Okay. The first key takeaway is that revised, optimistic global outlook. The health workforce stock is growing significantly faster than the global population, and that leads to a projected 2030 shortage of 10.2 million, which is a substantial improvement on that initial catastrophic estimate.
Second, the alarming regional concentration. This global progress is masking a profound, deepening crisis of equity. By 2030, nearly two-thirds, 69% of the remaining global shortage will be tightly clustered within just 47 high-risk countries, primarily in the African and Eastern Mediterranean regions.
Third, there's the promise. Generative AI offers truly transformative potential. LLMs and multimodal models promise scalable, personalized, and high-fidelity training environments capable of addressing the severe educational capacity constraints that are feeding the shortage in LMICs.
And fourth, the structural reality check. This technological promise is severely undermined by complex, intersecting structural barriers. These include ethical risks like hallucination and systemic bias, accessibility issues related to the digital divide and the overwhelming reliance on English, and, critically, the financial gap in both customization and sustained high absorption capacity.
So we have a perfect solution, but the very conditions required to deploy it fairly, resources, infrastructure, local language support, are least present in the 47 countries that need it most.
So what does this all mean for the next decade of global health policy? This is where we leave you with a final provocative thought to mull over.
We've established that the health workforce crisis has two parts: the ability to train workers, which is where AI can help, and the ability to hire workers, that's 70% absorption capacity, which requires public funding. If international aid and policy focus heavily on funding the exciting technological training solutions, the AI without simultaneously funding the sustained public expenditures required to create the jobs and ensure that 70% absorption rate holds.
Are we inadvertently setting the world up for a future where high-income countries benefit from hyper-efficient, AI-trained staff, while the 47 high-risk countries face an even larger class of unemployed, highly trained graduates?
If the digital solutions designed to alleviate the global health crisis only widen the economic and technological divide, we ensure that the concept of universal health coverage remains an unattainable dream. The urgent policy challenge is to fuse the investment in training tools with the investment in the actual human capital, the salary lines and public budgets required to retain them.
A compelling challenge indeed, and one that requires us to look beyond the hype and focus on the fiscal reality. Thank you for diving deep with us.